So yes, so today in this class we are going to discuss treatment of Parkinson's disease. So in the last class we have seen what is Parkinson's disease, what was the pathophysiology behind it, what were the signs and symptoms, what were the clinical findings, and how to diagnose Parkinson's disease. All this we have discussed in the last class. So now today in this class we are going to discuss treatment of Parkinson's disease. Okay. So what were the goals of treatment? So first, in any disease, the first goal of treatment is to minimize the symptoms, to minimize the disability. Why? Because they will be unable to stand properly, they will be unable to do their normal activities. So we should try to minimize this disability and also the side effects with and also side effects which will get after using these medications, that also we should try to minimize. And also we have to improve the quality of life of the patient, and also education of the patients, like education of the patient regarding their disease and regarding how to overcome these difficulties, and also education of the caregivers, providing exercises which were relevant to them, and proper nutrition. So all these were the main goals of treatment. So when coming to management, it can be managed by three different ways. One is pharmacotherapy, non-pharmacotherapy, and surgery. So first we'll be discussing pharmacotherapy of Parkinson's disease. Okay. So this is the flow chart which is showing like algorithm for how to treat this Parkinson's disease. So once the diagnosis of Parkinson's disease was done, first we have to go for non-pharmacological treatment if it is in the initial stages. It includes education, exercise, nutrition, and psychosocial support. Psychosocial support can be given by a number of counseling sessions, so because and meditation and all. So with that we can provide this psychosocial support. And coming to pharmacological treatment, first we have to consider giving rasagiline. Rasagiline, what is a rasagiline? It's a rasagiline, or any we have to start with rasagiline, which is an anticholinergic drug, and then again after starting that medication we have to check whether there is any control in the tumors or not. And if there is actually rasagiline is a COMT inhibitor, and if the tremors are there, then we have to consider anticholinergic drug or amantadine. So for that rasagiline we have to add anticholinergic or amantadine. And again, if the age is greater than 65 years, in that conditions we cannot go for anticholinergic, just we have to add amantadine. And if there is bradykinesia, rigidity and tremors, even though after using this medication, then we have to add amantadine, dopamine agonist, or carbidopa or levodopa. So this should be added if the age is less than 65 years. And if it is greater than 65 years, we have to add amantadine and carbidopa or levodopa. First is, if the age is less than 65 for tremors, we have to add anticholinergic or amantadine. If bradykinesia, rigidity and tremor, then we have to add amantadine or carbidopa or levodopa. If the age is greater than 65, here we have to add only amantadine. Here we can give both amantadine and dopaminergic agonists. And then management of motor fluctuations. So for the management of motor fluctuations, for that we have to increase the dosing frequency of levodopa. So once, if it is initially we are giving at the rate of once in a day, then we have to increase it to twice a day or thrice a day depending on the severity of the motor fluctuations. And then we can add MAO-B inhibitors or COMT inhibitors and add a dopamine agonist. And for management of peak dose dyskinesia, so for that peak dose dyskinesia, that means because of overdose of these medications, if they are getting this dyskinesia that is unable to completely move, then we have to go for reduce the dose of dopaminergic drugs and also add amantadine. And then need for symptomatic control of motor complications. So despite this pharmacotherapy, we have to even though if the condition is not improving, then we have to consider surgery. Okay. So this is the flow chart, treatment algorithm for Parkinson's disease. Okay. First we have to, once it's diagnosed, first we have to check whether it can be treated with non-pharmacological treatment. If not, we have to go for pharmacological treatment. If first we have to start with rasagiline. If the patient is complaining of tremors, we have to add amantadine and anticholinergic for if the age is less than 65. Greater than 65, only amantadine. And bradykinesia, rigidity and tremor are there. Then we have to add amantadine and carbidopa or levodopa. The same thing even for the age greater than 65 years. Even after taking these medications, if the patient's motor fluctuations were not improving, then we have to increase the dose. If there is high dose, because of high dose, if the patient is complaining of any side effects, then we have to decrease the dose. Even after using all these medications, if the patient is not responding, then we have to go for surgical procedure. So coming to these anti-Parkinson's drugs, here is a list of drugs, dopaminergic drugs. In that, dopamine precursors, peripheral decarboxylase inhibitors, dopamine agonists. Again, in that, ergot derivatives, non-ergot derivatives, MAO-B inhibitors, dopamine facilitator, COMT inhibitors. And anticholinergic drugs include anticholinergics and antihistamines. So dopamine precursor, levodopa, this thing you have to remember properly. Dopamine precursor is levodopa because it's a prodrug. After metabolizing, it gets converted into dopamine. Peripheral decarboxylase inhibitor, so that is carbidopa and benzerazide. They will prevent the peripheral conversion of active drug to inactive drug. So by that mechanism, by inhibiting that step, they will make more availability of dopamine in the circulation. And dopamine agonists, ergot derivatives like bromocriptine, pergolide, lisuride, gabergoline. Non-ergot derivatives, pyripedyl, ropinirole, pramipexole, apomorphine, and rotigotine. MAO-B inhibitors like salagilin and rasagiline. These were the MAO-B inhibitors. This will be given as a first line of drug. So first we'll be starting with rasagiline. And then dopamine facilitator, the example of it includes amantadine. So this is also main drug which we are using. And COMT inhibitors like entacapone or tolcapone. And anticholinergic drugs, trihexyphenidyl, benzotropine, procyclidine, piperidine. Antihistamines like diphenhydramine or orphanadrine and promethazine. These were the antihistamines. So these were the drugs. Coming to this pharmacological therapy, like if you are going in detail into few drugs, anticholinergic medications, what does they do? They can improve tremors. So anticholinergic drugs, they will decrease the acetylcholine. So once there is decrease in the acetylcholine, tremors like activity will be decreased. So for that purpose, we will be adding anticholinergic medications. And also sometimes dystonic features. That means there is movement of, there is changes in the tonicity of their body. Then in that conditions also it will be helpful. And it doesn't show much use when there is bradykinesia or any other disabilities. So it can be used either as a single drug, that is monotherapy, or it can be used with along with other anti-Parkinson's drugs, like it can be used along with rasagiline, which is a MAO-B inhibitors, and or any other like carbidopa or levodopa. The side effects include dry mouth, blurred vision, constipation, urinary retention, forgetfulness, confusion, sedation, depression, and anxiety. So these were the main side effects of anticholinergic medications. And patients with already, if they are already having some cognitive deficits like memory loss, and the elderly, they are at risk of getting this central anticholinergic side effects. Central anticholinergic side effects include blurred vision, depression, anxiety, sedation. So all these, the risk of getting the side effects will be more if the patient is already having some cognitive dysfunctions, or if the age is more. In that conditions, the risk of getting side effects is more comparatively. So this is about anticholinergic drugs. These were mainly used for tremors and also dystonia. So in these two conditions, if the patient is having in Parkinson's disease, it is of best choice, and it can be used as monotherapy and also as a in combination with other anti-Parkinson drugs. And then coming to amantadine, which is a dopamine facilitator. So it provides modest benefit for tremors, rigidity, and bradykinesia. And adverse effects include sedation, dry mouth, hallucinations, dizziness, confusion, and a diffuse mottling of the skin in the upper or lower extremities. So it's a reversible side effect. So these were the side effects of using amantadine. And as it is excreted through unchanged in the through urine, so we have to be very careful when we are giving it in kidney patients, like who are on chronic kidney disease or who are on dialysis. In that conditions, in that patients we have to make some dose adjustments. So if depending on that, the dose was given here. So if the creatinine clearance is 30 to 50 ml per minute, 100 mg every other day for creatinine clearance. So then 200 mg and 7 days for creatinine clearance less than. So every time we have to repeat the creatinine clearance test, and then we have to adjust the dose. And then coming to levodopa and carbidopa. So levodopa is nothing but dopamine precursor. Carbidopa, it's like a carboxylase inhibitor. So levodopa, it acts as a precursor of dopamine. That means it's a prodrug. When it is metabolized, it will be converted into dopamine. Levodopa is a precursor or prodrug on metabolism. It will be converted into dopamine. The best thing with this levodopa is it can cross the blood-brain barrier. So whereas other drugs, they cannot cross this blood-brain barrier. So like when to start this levodopa is controversial. Like some people, they say that immediately after the patient is diagnosed with Parkinson's, they can start this levodopa. In some, it was found to be like after using different medications, if they are not responding, only at that time we have to go for L-dopa. So there is so many controversies were running out, like when to start this levodopa. And in the CNS and peripheral, it is converted by L-amino acid decarboxylase into dopamine. In the central nervous system, it is converted in this way. And then in the periphery, like peripheral circulation, then carbidopa or benzerazide can block this amino acid decarboxylase. So thereby it will be helps in, so if see, actually it has to be converted into dopamine, L-dopa to dopamine only in the brain. That means in the central nervous system, if that conversion takes place, then that will be utilized by the neurons, like neuronal cells. Where if it is converted in before crossing this blood-brain barrier, then it will not be of no use. So that conversion in the peripheral circulation is inhibited, is blocked by carbidopa or benzerazide. They will inhibit this amino acid decarboxylase so that it is sent as it is to the brain, and once it is in the brain, it is converted into active drug. So this is how carbidopa is useful. So in order to provide better treatment, it is best to use carbidopa along with levodopa. Okay. So the dose and the side effects of L-dopa include postural hypotension, vivid dreams, cardiac arrhythmias. And initial dose could be like 300 mg per day. It can be given in divided doses, and it provides good treatment, provides good relief from the disease when it is given along with carbidopa. Okay, and the maximum dose it can be given is like 800 to 1000 mg per day. And carbidopa like 75 mg is required in order to provide sufficient help to this levodopa. Okay, so controlled release preparations were available, and for the patients who are unable to swallow, for them like oral disintegrating tablets is also available. Like if we keep that, like we will be like Digene, like oral disintegrating tablets is also available. So adding carbidopa or benzerazide, they can extend the half-life to 1.5 hours. And a COMT inhibitor like entacapone can extend it to 2 to 2.5 hours. So adding either COMT inhibitors or carboxylase inhibitors like carbidopa or benzerazide, that will improve the half-life of levodopa, that will give effective treatment. Like effective relief can be given when it is given along with carbidopa or benzerazide or COMT inhibitors. Okay. And on long-term use of L-dopa, it causes certain motor complications. So that may be disabling. So it includes end of dose wearing off. So that is related to increasing loss of neuronal dopamine storage capability and the short half-life of L-dopa. End of dose wearing off. So that means it causes increased loss of neuronal dopamine storage. So there will be severe loss of dopamine storage because of this decreased half-life of L-dopa. So bedtime administration and sustained release formulation and transdermal patches, extended release. So these were the different formulations it was available. So if you are giving it during night times, so if you are giving these medications in the night time, it will improve the functioning in the daytime. So it is better to advise this medication in the night times. Delayed or no on can result from delayed gastric emptying or decreased absorption in the duodenum. That means because of delayed gastric emptying or decreased absorption in the duodenum, whatever the drug that we have given, that is not properly absorbed. So the effect produced will be very much delayed, or sometimes there will not be any result after using this medication also. So crushing carbidopa and taking with a glass of water or using oral disintegrating tablet may helpful. So why? Because oral disintegrating, there will be rapid absorption will be there, or if you dissolve, if you are making it into powder and dissolving, then the absorption will be rapid. So in that conditions, we can prevent this delayed on effect. That means late effect or no effectiveness of the drug can be cleared if you are taking this as oral disintegrating tablet. Why? Because absorption will be more, and also it is better to take on empty stomach so that absorption will be more. And freezing episodic inhibition of lower extremity motor function may be caused by anxiety and may increase falls. So freezing like activity also may cause falls. This falls means you will be falling down. And then dyskinesias, involuntary coriform movements usually involving the neck, trunk and extremities are usually associated with peak striatal dopamine levels. So these kind of symptoms can be seen when there is more amount of dopamine after using these medications. So that overdose should also not be done. And then off period dystonia, that is muscle contractions, most commonly in distal lower extremities, that is feet and toes, occurs often early in the morning. So it is better to give this medication in the night time, that too as sustained release tablets. And also if it is required, you can use baclofen or selective denervation with botulinum toxin in order to prevent this, or in order to treat this dystonia caused after this using these medications. So here is a change. Common motor complications and possible initial treatments. If there is end of dose wearing or motor fluctuations, in that time we have to increase the frequency and either add MAOB inhibitor or dopamine agonist. If this delayed or no on response, then you have to give it on empty stomach, or it can be given as oral disintegrating tablet or controlled release, and also we can use along with apomorphine subcutaneous. And start hesitation or freezing if the patient is complaining of freezing like symptoms. So we have, at that time we have to increase the dose, add dopamine agonist, MAOB inhibitor, or utilize physical therapy in order to relieve from that freezing kind of activity. And walking devices, sensory cues like rhythmic commands, stepping over objects, so that kind of things should be done in order to prevent the patient from to bring out the patient from freezing like activity. Peak dose dyskinesia, that means because of high dose, if they are having dyskinesia, at that time we have to decrease the dose, smaller dose, and add amantadine. So these were the complications, and these were the initial treatments to treat these motor complications. So here is a flowchart indicating different drugs and drug interactions, monitoring parameters in their comments. So when we are giving amantadine, it causes confusion, libido reticularis, and monitoring parameter, we have to check mental status, renal function, as it is unchanged in the excreted unchanged in the urine, we have to monitor carefully. Lower extremity examination, ankle edema. So if any of these were found, then we have to reduce the dose, especially in the renal impairment, and reversible upon drug discontinuation. So ankle edema is reversible upon drug discontinuation. Benztropine, it's an anticholinergic effect, causes confusion, sedation. So whatever the side effects of anticholinergics that can be seen here, if they were found, we have to decrease the dose. And trihexyphenidyl, C-benz, again the same. Carbidopa or levodopa, they cause drowsiness, dyskinesia, and nausea. So we have to ask, because of drowsiness, we have to ask the patient whether he is having daytime drowsiness. If he says so, we have to reduce the dose. And dyskinesias, abnormal involuntary movements, at that time we have to reduce the dose and add amantadine. Nausea, so if the patient is complaining of nausea after taking the food on empty stomach, then it's better to give along with food. CONT inhibitors like entacapone or tolcapone, so they will cause augmentation of L-DOPA side effects, also diarrhea, and reduce dose of L-DOPA and antidiarrheal agents. We should add antidiarrheal agents. And apomorphine, dopamine agonist, bromocriptine, they also cause these kind of adverse drug reactions. So again, we have to reduce the dose. And pramipexole, ropinirole, rotigotine. So for all these, we have to reduce the dose. We have to check their mental status, behavior, blood pressure, and depending on that, whether we have to reduce the dose or titrate the dose. So depending on that, I outtake give along with food. So these were the things we have to check. And MAO-B inhibitors like rasagiline and selegiline. So rasagiline causes only one adverse effect, that is nausea. So we have to give along with food in order to prevent that nausea. Selegiline, it causes confusion, insomnia, hallucinations, orthostatic hypotension. So we have to regularly monitor their mental status, blood pressure, and dizziness upon standing. So if there is orthostatic hypotension, patient will feel dizziness once standing. So in that conditions, we have to reduce the dose. So this is all about the pharmacological treatment. And now coming to non-pharmacological treatment. So first is healthy eating. So it includes, they should take a nutritionally balanced diet which contains plenty of fruits, vegetables, and which is a food containing high fiber, and drinking a large amounts of liquids and fluids, and in order to prevent this constipation which is common in Parkinson's disease. And this provides nutrients such as omega-3 fatty acids which is required for the brain development. So this will help in the Parkinson's disease, and anti foods which are rich in antioxidants. All this will help in Parkinson's disease. And exercising. So the exercises which we have to do, which will strengthen the muscles and the flexibility and balance, which exercises will help in maintaining the balance. So that kind of exercises should be suggested. And they also provide some good well-being, and also they'll reduce the depression and anxiety of the patient if they makes a habit of daily doing this exercise. And try not to move too quickly. So should not they should do it in a stepwise approach, and aim for your heel to strike the floor first when you are walking. So first when they are walking, first they should keep their heel and then they should start walking. If you notice yourself shuffling, stop and check your posture. If you find that you're moving while walking, then stop there and check the posture, like how you're walking. And it's best to stand up straight. So instead of standing or leaning or bending this way, it's better to stand up straight. Look in front of you, not directly down while walking. So when you're walking, just look forward, don't look down while walking. Why? Because it may cause further dizziness. So that because of that only they should look straight instead of looking down while walking. And avoiding falls. So in the later stages, there will more chance of falls because of this bradykinesia or their unbalanced. So in that conditions, you should be very much careful, should avoid falls. So which will help in avoiding falls? Make a U-turn instead of pivoting your body over you. So instead of bending this way, it's better to turn. If you want to move that side, instead of turning this way, just make a U-turn. And keep your center of gravity over your feet without leaning or reaching. So it's better to always stand instead of bending in this way. And avoid carrying things while you walk. So don't carry anything while you walk. Why? Because it may cause some slipping. Avoid walking backward. Should not walk backward. Only walk forward. That too by looking straight forward and don't look down. So and instead of turning around, it's better to make a U-turn. So these may helps you to avoid falls. And daily living activities such as dressing, eating, bathing, and writing, all this may be difficult for these peoples. So some occupational therapist, whoever he is there, he will show how to like some techniques, like how to do all these activities by himself. So by going to that classes, so that you can do your activities, which will help you a lot in keeping your life so simple and easy. And then so we have discussed pharmacological treatment, non-pharmacological treatment. Now we are going to discuss surgery. So there are 3 different types of surgical processes available for both Parkinson's disease and epilepsy. So first is deep brain stimulation. That means deep brain stimulation, stimulation of the brain from the deeper layers. That is deep brain stimulation. So if you see in this picture, they will place an electrode. they will place an electrode deep in the layers of the brain, and to that here there is a pacemaker. This is a subcutaneous extension wire. So here is an electrode. Up on the top of this there will be some lead, so which will always makes the brain to get stimulated. So it will send some electrical impulses which will stimulate the target area to on which this electrode was placed. So it was placed surgically in the brain. It may be used in addition to therapy by using along with medications. Also, they can go for this deep brain stimulation. So by this method, it does not cause any brain tissue damage, and it has fewer risks than other older techniques which were used, more destructive surgical methods such as pallidotomy and thalamotomy. Previously, pallidotomy, thalamotomy were done. They may cause certain brain tissue damage, but by using this deep brain stimulation, it does not cause much damage to the brain tissue. Just what will they do? They will keep an electrode deep in the brain, and for that they will connect a pacemaker, and it will continuously send some electrical impulses. So by that electrical impulses which was placed in the particular area of damage, so it will continuously stimulating that area. So yes. So next is deep brain stimulation, and next pallidotomy and thalamotomy. So what is pallidotomy, thalamotomy? So these two are the surgical procedures in which an incision is made in the palladium. Here they will make an incision in the thalamus region, which will destroy the which will remove the damaged tissue which was damaged. So that will be removed, and by that